Good afternoon, everyone, and it's a pleasure to be here virtually with you and to give this talk on a practical approach to dystonia. So these are my disclosures, and I highlighted here the ones possibly related to what I'm going to tell you this afternoon. Let's start with a classic dystonia definition. This is a new definition that was published in 2013 in the consensus paper by Albanese et al. And I'm going to refer to this paper quite a lot during my presentation. So dystonia is a movement disorder, as we know. It's involuntarily characterized by a combination of dystonic postures or dystonic movements or both, sometimes some tremor. And this can be initiated or even worsened by voluntary actions, as you'll see later. There are other associated features that are important to recognize, like sensory trick, dystonic tremor, overflow, and mirror dystonia. We're going to have a look at this right now in a rapid sequence. But let's start with showing some movements on your left and some posture on your right. Clearly, the first one is a more phasic movement in a patient with blepharospasm or mandibular dystonia and torticollis. On the right, instead, you see a younger patient with a dystonia of the foot. And these are just examples, and this can be variably combined. Dystonia can start just during a particular task, like you see in the video in a person with writer's cramp that only has a tremor and dystonia while writing and no other features of dystonia or even tremor during other actions. In the picture, you see musician's dystonia, which is another type of task-specific dystonia, where there is dystonia on one hand and also on the lips, clearly indicating that the overuse of this particular muscle causes this dystonia. But usually in the disease progression, the dystonia is no longer task-specific, but it becomes movement-specific. Anytime there's a movement. And finally, the highest degree of severity is when dystonia is present at rest, and still it can be worsened by voluntary action. Sensory trick. Sensory trick is something that the patient does, just a gentle movement to correct the dystonia. It doesn't have to be a mechanically strong movement, but simply, like in this case, a light touch on the chin is enough to improve dystonia remarkably. And it's been seen in studies, like you see down there in the slide, but also clinical experience that teaches that over time, the sensory trick becomes less and less effective. Dystonic tremor can be associated to dystonia. On your left, you see a dystonic tremor of the right arm in someone with writer's cramp and cervical dystonia. On your right, you see a dystonic tremor in a patient with torticollis, with cervical dystonia. And this is the classic dystonic tremor, where dystonia and tremor are present in the same body part. But sometimes we have conditions like this woman here. She has a laryngeal dystonia, but also some action tremor that you'll see in a second on posture of their upper limb, so symmetrically. And here on your right, instead, you see two patients belonging to the same family. The woman has cervical dystonia and she also has an action tremor of the arm. Instead, the man has only an action tremor with no dystonia, and the action tremor involves the upper limbs. So the first one you see here is, again, a classic example of dystonic tremor. This is a man with torticollis and tremor on the neck. So this is where dystonia and tremor are in the same body part. What you see at the center is tremor associated with dystonia, because dystonia is present in the same individual, but somewhere else in the body. And what you see here on your right has been called in the past tremor associated with the dystonia gene, because the patient has tremor that looks like essential tremor, actually, and dystonia is present in someone else in the family. And as I mentioned already, these two types of tremors are actually called sometimes ET-like tremors. ET stands for essential tremor, because they are very similar to what you see in essential tremor and respond to the same medication, sometimes even to alcohol, even though we don't think this is essential tremor, because we know that this tremor has something to do with dystonia. Overflow means that anytime there is a voluntary action, like in this example here, there's an activation of other muscles distally, in this case, the shoulder. And mirror means that when the patient moves, like in this case, is moving the right side, the left side does something similar. So this is another classical feature of dystonia. And I want to show you another example of mirror movement. This is a man with a dystonic tremor on the right, and also some dystonic posture of the thumb. He has some writer's cramp when he tries to write. But what I want to show you here is the mirror dystonia. So I'm now asking the patient to do some fine movement on the right. You'll see that he'll have some minor mirror movement on the left. And this will be even stronger when he does the same on the left side, because obviously the right side is more affected. So this is typically a mirror dystonia. You see more mirror dystonia on the affected side. I also need to emphasize, and this is just an example, that people with dystonia have a variety of non-motor problems, usually anxiety and depression, and that goes beyond the disability caused by dystonia. It's probably an endophenotype of the disease, and a classic example in this regard is dystonia myoclonus, where you see high prevalence of psychiatric problems. So back to the paper by Albanese et al. In 2013, how we classify dystonia is shown here. We have an axis one, which basically looks at the clinical characteristics of the patient, and also an axis two, which looks at the etiology. And usually when you do a good job in axis one, you start to understand what's a possible etiology, as you'll see in a second. But clearly, etiology can be identified as when there's a structural problem, when there's acquired, like in a stroke, for example, when there's genetic, and when it's idiopathic, when you don't know what's the real cause. And most of the time, we think that idiopathic dystonias are caused by a gene that is not understood yet. But back to the clinical characteristics, obviously we characterize dystonia by age at onset, more importantly by body distribution. And you here see some example. In A, you see a patient with blepharospasm, eye closure, which is a typical focal dystonia. In B, you see segmental dystonia called MAGE syndrome, because you have a combination of oromandibular dystonia and blepharospasm. So we call this MAGE syndrome. C, you see an example of torticollis. And this man, as you saw already in the previous picture, also has upper body dystonia. So it's another example of segmental. Multi-segmental is when there are multiple sites involved, but they are not next to each other. In D, you see a writer's cramp. In E, you see another example of generalized dystonia, in this case affecting the trunk, the upper limbs, the face. And in F, you see another example of generalized dystonia where you have a more widespread involvement of the whole body. And this is actually a status dystonicus, something I'll tell you later today. And you can also have dystonia on one side of the body, and this is called hemibody dystonia or hemidystonia. And classically, hemidystonia means that there's a structural lesion, usually contralateral to where you see the dystonia. Temporal pattern is also important to recognize. We have a disease course that can be static or progressive, and also the dystonia itself can be variable, meaning that it can be always the same severity, or action specific, as you heard already before, or you may have diurnal fluctuations, or it can be episodic, something we call paroxysmal. So this is an example of generalized dystonia. This is the very first gene that was discovered in the dystonia field. Is a TOR1A gene, which is usually present in Jewish Ashkenazi patient, but this is actually seen in other patients as well. Like in this patient, is one of the patients I saw a long time ago when I was practicing in Italy. And you can recognize that this dystonia tends to start from the lower limbs and then progresses pretty fast. And this is a few years later, right before getting deep brain stimulation. This used to be called DYT1 dystonia, typically affecting the children, and responds well to surgery, as you'll see later today. And it's called DYT1 because it's the first gene ever found in dystonia. This condition was initially described by Oppenheimer 2 centuries ago almost. And what I also want to say with this slide is that we don't use the classification DYT1, 2, 3, and 4 anymore. We want to use DYT and then the gene causing the problem. These are obviously DYT1 is a typical example of progressive dystonia. Instead, status dystonia tends to be the acquired one. On your left, you see a patient with cerebral palsy. In cerebral palsy, you have a combination of dystonia, but there's also weakness sometimes spasticity, sometimes dysarthria. And on your right, you see a trunk dystonia that we call Pisa Tower syndrome, because it resembles the Pisa Tower, and this is typically caused by neuroleptics. On your left, you see a case of fluctuating dystonia. This is typically seen in a condition, again, affecting children called Dopa responsive dystonia. I'll tell you more about this in a second. And these patients tend to have worsening of their symptoms in the evening. On your right, instead, you see a patient that after some exercise starts to have a lower limb dystonia. And this is called by a mutation of the gene encoding for the GLUT1, which is the glucose transporter. You see that with more activity, the patient has more dystonia. And in GLUT deficiency syndrome, you might have what you see here, which is called paroxysmal exercise dystonia. Let's talk a little bit about paroxysmal dyskinesias. This is the general chapter, but most of the time in paroxysmal dyskinesias, you have dystonia, as you see here from the table. And there are three main types: kinesigenic, which is usually very brief, very common, and usually triggered by a sudden movement; non-kinesigenic, which is usually triggered by alcohol, coffee, strong emotions, and it lasts longer and is seen less often during the day; and then exercise dystonia, which I just described. Now, as you can see from this slide, on your right in particular, there is a variety of genes that can cause these different conditions. So there is heterogeneity from a genetic standpoint. This LC2A1 is the GLUT1 transporter I mentioned before, but other genes can be involved, including genes causing Parkinson's disease, like PARK2. The biggest gene for the non-kinesigenic form is this MR1. The kinesigenic one is more heterogeneous with more genes, not just the PRRT2, which is a very pleomorph gene. It's a gene that can cause many diseases. And this is one of the genes you saw listed there, ATP1A3. And this is an interesting gene which has a variety of manifestations. This is a patient we reported a while ago. Is a patient with generalized dystonia. And on top of the generalized dystonia that tends to progress, sometimes in a very fast fashion, you also have crisis. So you have episodic worsening. So you have a combination of a progressive dystonia with some variability during the day. Another reason to look into variability is the so-called status dystonicus or dystonic storm, which is defined as a severe worsening of the dystonia requiring a hospital admission. And you already saw before that there is a variety of progression of the disease. We talked about task specific that becomes movement specific that become dystonia at rest. But dystonia also in terms of body distribution can present in a part of the body, so as a focal dystonia that can become segmental and then generalized. Generalized in the past would require an involvement of the lower limbs. Now we say that generalized is anytime there's also trunk involvement. And then there's a further progression, which is this status dystonicus that I just mentioned. Status dystonicus has a mortality of about 10%, if not promptly recognized and treated. But if treated, the patient goes back to the pre-existing dystonia, as you see in this patient here, which is a patient with cerebral palsy. But actually, status dystonicus can be seen in a variety of conditions, also in DYT1 patients, in MBIA, which is neurodegeneration with brain iron accumulation, also in acquired dystonia, as you saw in the video in the previous slide, cerebral palsy. So really a variety of conditions, including all the conditions causing striatal necrosis, either acquired or genetic, like glutaric aciduria. They can all cause a status dystonicus. And status dystonicus has particular triggers, as you see in this pie chart on a paper that we wrote a while ago. Infection is a big one, especially with high fever, but also metabolic problems, drug changes. In this case, either the introduction of certain drug or the withdrawal of certain other drugs. And this is particularly the case of Wilson's disease, but also sudden problem with the deep brain stimulation device, like you see in this man here. This is a patient with Parkinson's, and the sudden discontinuation of deep brain stimulation causes this upper body dystonia, which also involves the oromandibular region and impairs his ability to speak and swallow. So this might become a medical emergency, as you can tell. That's why it's important for you to recognize it. Some people think this is epilepsy, but it's not, and also to treat. And I'll tell you later how to treat status dystonicus. Also important in the classification to recognize the associated features. because this tells you what to look for and how to reach the final diagnosis. And when you look at the associated features, you may only deal with dystonia, and this is something we call isolated dystonia, or dystonia can be combined, and can be combined either with other movement disorders, or either with other neurological signs, or even with systemic problems. And I'm going to give you a few examples. Isolated dystonia is typically represented by the DYT-TOR1A that I already presented, but there is also DYT TAP 1, which used to be called DYT6, you see in this video here. This is a more focal or segmental dystonia involving the upper part of the body, usually involving more slowly progressive, and usually involving the adult population. And then there are newer genes like NAL or ANO3, which is also commonly presenting with tremor, which are obviously rarer, and we're just getting to know these genes a bit better. These are isolated dystonia. Dystonia can be combined with movement disorders. In the case of Parkinsonism, this is a man from the Philippines, and this is the classic Lubag syndrome or Lubag disease, which is a X-linked type of Dystonia Parkinsonism caused by a mutation of the gene TAF1. Another example of dystonia combined with Parkinsonism is the dystonia you see in Parkinson's disease, which typically responds to levodopa. This is a patient with early onset Parkinson's disease and lower limb dystonia, which looks like a foot drop, but this is no weakness. This is dystonia, and it goes away when the patient walks on the heel, or when you ask him to do additional tasks like running. And as you can see from the video, the patient has no weakness. Another example of dystonia combined with Parkinsonism is what you see in Dopa responsive dystonia, which is a very important type of dystonia because it might respond beautifully to levodopa, as you'll see later. The most common gene is the GTP cyclohydrolase 1, which is a gene involved in the production of biopterin, BH4, which is a cofactor for the production of many monoamines, as you see here in this slide. Another important one is the TH, the tyrosine hydroxylase, which is the final step for the conversion of tyrosine into levodopa. And then there are other genes like the tryptophan hydrolase or the AADC that can be involved and cause Dopa responsive dystonia. But these are rare forms of dystonia that you don't necessarily need to know. Really, the most important take-home message here is that these are people with dystonia, usually early onset, so during childhood, very early actually, especially TH can present right after birth. And in these cases, there is always something else, sometimes a little bit of Parkinsonism, sometimes depression, sometimes dysautonomia, because as you can tell, there is the involvement of other aminergic systems. You can also diagnose this condition looking at the CSF or blood or urine biomarkers. I don't want to get too much into details here, but this is just to make the point that looking at certain biomarkers that you see listed here, the ones that are blue are usually low, the ones that are red are usually high, the other ones are normal or not available. And making a comparison of the different metabolites that you test, you can infer what type of genetic mutations you're dealing with. Obviously, today is much easier to do a genetic panel, but you can also reach a diagnosis looking at these biomarkers. Dystonia can be combined with other movement disorders other than Parkinsonism. This is the case of myoclonus. I mentioned already Dystonia myoclonus, and which is typically caused by the sarcoglycan epsilon gene. In these patients, usually there's a good response to alcohol. There is usually a variety of psychiatric problems. It's an autosomal dominant disease, relatively common in childhood. And this case you see here is quite unusual because dystonia is affecting the lower limbs. Most of the time, dystonia affects the upper part of the body, and the patient has a mild torticollis and brightest cramp. These are the type of myoclonus you will see. Some patients have very minimal dystonia or no dystonia whatsoever. This is a condition that used to be called essential myoclonus, where you only see a subcortical myoclonus, but we now know that this is all caused by this gene. So mind you that other genes can cause something similar to this, including the gene causing DYT1, but we tend to call this no longer dystonia myoclonus, we call it myoclonic dystonia, So just to make the difference with dystonia myoclonus, which tends to be caused by the epsilon sarcoglycan gene. There are rarer conditions causing a combination of dystonia and ataxia. This is the sequestrosome gene, is an autosomal recessive form. The patient have dystonia, sometimes correct movement, and ataxia, as you see in a second when the patient walks. These are very rare syndromes, exactly like the BPS 41, just another example of a very rare syndrome. This is just to really say that dystonia and ataxia can really be caused by a number of genes, and that's another example of SCA35, which is typically obviously an ataxia gene, but this man has very little ataxia and he has a cervical dystonia. Has been described also, this man has Bradder's cramp. It's been described also with cervical dystonia in the Japanese population. Really, this is not for you to remember, just to make the case that there is a variety of genes that can cause dystonia and ataxia. Now, dystonia can be associated with other features, not necessarily this movement disorder. This is a young patient with something very similar to the DYT-TOL1A dystonia, lower limb involvement, rapid progression towards the upper part of the body. In these patients, probably there is more speech involvement, more laryngeal involvement, but this patient might have additional features. Some of them might have hypointensity of the brain MRI, but really sometimes it's difficult to differentiate them from the classic DYT-TOL1A that we used to call DYT1. But some people, and that's the point I'm trying to make, have other features like dysmorphic features. It's seen in 1/3 of the patient, and you see a number of features that have been described. But sometimes if you don't have the right eye, and this is usually the case for adult neurologists, you might not recognize this feature. Instead, pediatric neurologists are very good at picking up these dysmorphic features. Sometimes dystonia can be associated with systemic issues like liver dysfunction, and this is typically seen in Wilson's disease, an autosomal recessive condition characterized by excessive accumulation of copper, which also causes generalized dystonia, tremor, Parkinsonism, mental issues, intellectual disabilities. Really, is a variability of presentation, and you need to know this. This needs to be recognized early enough, especially in young patients, because there is a treatment. Other conditions where you may see an accumulation of metal, in this case iron, is what you see in the so-called NBIA, neurodegeneration with brain iron accumulation. And the most common one is the pantothenase kinase associated neurodegeneration, or caused by the gene PANC2. And this is an autosomal recessive condition. Most of these conditions are autosomal recessive, as you see. Very few are they are inherited in a different way, and they are all sharing this peculiar accumulation of iron in the brain. Now, depending on the type of accumulation in the brain and what other features you see, like for example, in this one, you will see the so-called eye of the tiger sign, you can reach a final diagnosis. The treatment, unfortunately, still remains symptomatic. These are combined dystonia with a variety of other neurological problems, from spasticity to retinitis pigmentosa, optic atrophy, or seizure. So really, this is a very complex chapter of neurology, and particularly pediatric neurology. What's now known is that the iron itself is not necessarily culprit of the issue. Most of the time it's just an endophenotype, and that's why unfortunately treatment with iron chelators are usually not effective. Keep in mind that there are also a number of mimickers of dystonia, which are usually orthopedic condition. And what these conditions have in common usually is a more static type of dystonia, or fixed dystonia, like in this case. Now, this is a woman with fixed dystonia caused by functional dystonia. So psychogenic dystonia is another big chapter. And in psychogenic dystonia, you tend to have a more tonic presentation. So this is a case of a young patient who failed anything. He was treated with drugs, with botulinum toxin, and he was sent to me for deep brain stimulation. But you can tell that this man lacks the classic features that I told you before. He doesn't have dystonic movement, he doesn't have dystonic tremor, dystonic posture, he doesn't have sensory trick, even though some of these patients might even have sensory trick. And this man has a functional dystonia, which is a fixed dystonia most of the time. And it's been reported, as I said already, that some of these functional patients might also have a sensory trick. And in this recent paper we wrote, we found out that 50% of patients referred to us for deep brain stimulation are not getting DBS, and 45% they are not going to get DBS, they are not even waiting for DBS, and very often this is because of a functional diagnosis. So it's important to diagnose the functional diagnosis, the functional dystonia, because otherwise this patient might end up having surgery. Let's now talk about the approach to dystonia. So the general approach is important. First things, you need to look for treatable causes of dystonia. Then, depending on the type of distribution, you might decide whether to use drugs or topic injections of botulinum toxin. And more importantly, you need to educate the patient and the family, because dystonia is still a really rare disease, and not everybody, not many physicians or even neurologists are familiar with this condition. So, treatable cause of dystonia. I already mentioned the Dopa responsive dystonia. They respond beautifully to levodopa. Then there are other conditions where you may need to have a modified diet. Vitamin E can be used in certain type of dystonia. Thiamine and biotin can be used in a very particular type of acute onset dystonia of the childhood. And Niemann-Pick type C also as a specific therapy. But here I want to show you the beautiful response to levodopa in a patient with DRD. This is the classic DRD, autosomal dominant inherited. And this is the mother of the patient, which had the same presentation, and she is still doing great years and years later. It's reported now that this gene mutation can also predispose to Parkinson's disease later in life. And this is something we have seen already. This is what happens when you delay the diagnosis. This is a patient who was diagnosed 18 years later. And unfortunately, even though he's still better on levodopa, he's developed a lot of deformities. And unfortunately, there's not much you can do in these cases. I already mentioned Wilson's disease that can be treated with copper chelator. Manganese transporter deficiency is another important one, which is also characterized by hyperintensity in T1 at the MRI, or the basal ganglia. And obviously there are also acquired causes that can be treated, the ones caused by drugs, the paraneoplastic, the one caused by infections. But in this case, you will see in infective cases, obviously, some MRI changes that will help you in the diagnosis. So how you choose the therapy? Well, there are different factors that you see here listed, but really the most important is the body distribution, because the more focal the dystonia, the more you use botulinum toxin, the more generalized the dystonia, the more you use oral medications. And then you can combine them. For example, you may use oral medication, and then if the effect is not the greatest, which is unfortunately what happens often, you go ahead and you do brain surgery. And patients usually do better, but they may still have a little bit of pain on the shoulder, and then you may still add a little bit of botulinum toxin just to ease the pain. So it's not one or the other. You can combine them as much as you want. There are specific symptomatic therapies for the paroxysmal dyskinesias that I mentioned before. You might use antiepileptics, you might use benzodiazepine, or ketogenic diet in the case of GLUT1 deficiency. Dystonia myoclonus has a particular type of flow chart, which we published a while ago. Zonisamide has been shown to be effective in a double-blind study, but also levodopa can be beneficial, benzodiazepine, anticholinergics, antiepileptics, and sometimes even medications that do the opposite of levodopa, like tetrabenazine, can be used. And if this fails, also deep brain stimulation is very effective. When it comes to the generic approach with drugs, remember the ABCD scheme. A as anticholinergic, B as baclofen, C as clonazepam or other benzodiazepine, D as dopamine, which is usually tetrabenazine. Rarely we use neuroleptics. We used to use them in the past. You see here listed the typical side effects and when to be careful with using these medications. And on your right, you see the doses. The message here is that you can go very high with the dose, but you need to do very slowly. Very often people think that anticholinergics are not effective, but most of the time it's because the side effects limit the maximum use the maximum dose that you can use. Kids can tolerate high dose up to 100 milligrams, but unfortunately as they age, these medications are no longer tolerated, and this is when you look into surgical options. This is a patient with cervical dystonia. In particular, this is a torticollis, a retrocollis with some neck pain that you will hear in a second, and this is what happens when he walks. The head wants to constantly pull backwards. So how is the pain now?
It's pretty bad.
On a scale that goes from 0 to 10, how much is it?
In the mornings, it's in the 7.
Pain is another big problem, especially in cervical dystonia. And this is the same patient telling me how he was feeling 7 weeks after an injection with botulinum toxin. As you can tell, the posture is much better, but also pain improves quite a lot. And this is the same man 2 years later, still keeping the same benefit, is now telling me how things are over time. This is another interesting case, one of the first cases I'm aware of treating with botulinum toxin in Italy. And you see that over the years, the effect of the toxin was still great. So important message to remember. Obviously, with COVID-19, dystonia clinic had suffered, and this is one paper showing that because of the delayed injection, the dystonia came back in everybody. So it's important to do these injections on a regular intervals of 3 months usually. And now, just towards the end of my presentation, I want to say a few things about surgery. This is a patient with DYT-TOR1A mutation who progressed over time and then improved after a pallidotomy, so a lesion of the pallidus. And then it worsened again. And this is when deep brain stimulation of the globus pallidus was done and improved. This was towards the end of the 90s. GPI DBS or pallidotomy is really life-saving in status dystonicus, but before you get there, you might treat this patient with sedation. You might consider this treatment like you would treat a patient with status epilepticus. You need to recognize status dystonicus right away, sedate the patient, admit him or her to the ICU, look at additional causes, fever, infections, correct the metabolic problems like rhabdomyolysis, which used to be the cause for death, causing kidney failure in these patients. But with sedation, the dystonia goes away. And then you might have therapeutic, you can have windows without sedating agents to see what happens to dystonia, to see whether dystonia is slowly improving. And if it doesn't improve, then you might consider brain surgery, which is very effective for generalized dystonias, as you saw before, but also for focal dystonia. This is a man with torticollis. You see how it does 4 years later. This is another man with laryngeal dystonia and orofacial dystonia.
Try to relax your arms in your lap.
And this is again how he improved, even though the improvement wasn't perfect, especially in these eyes after deep brain stimulation. We now know that there are certain genes that respond better than others. We now know that if you do surgery earlier, you do better because there is no deformities like you saw in the DRD patients before. We know the GPI is the target of choice, and we know that the higher the stimulation, the better it is. We've done a systematic review of DBS cases, and we've shown that TOR1A, TAP1, PANG2, which is the NBI genes that I mentioned, they all respond to deep brain stimulation. And the earlier the disease duration, the better it is. Disability is not necessarily improving in all of them. The greatest response in terms of disability is certainly coming from the DYT-TOR1A patients. But it's also important to look at negative trials. These are examples of conditions where DBS is being used for dystonia with not so good effect. So it's important to remember that not all the dystonias improve the same way. And usually surgical delay is a problem. This is a patient with mitochondrial dystonia, as you can see here from the striatal necrosis. And you can see also the degree of scoliosis that this patient developed over the years. And in spite of DBS, obviously, the trunk is not getting any better. This is another example of when the sagittal shift is not improving. And again, this is because of cervical arthritis. This is another example of a man with generalized dystonia and Parkinson's caused by a mutation causing Parkinson's disease, but he has a different type of gait. He has a spastic gait because DBS was done too late and the cervical dystonia worsened his condition because he caused a myelopathy. So DBS can fail when there are deformities, when the diagnosis is wrong, especially when you're dealing with functional dystonia, as I mentioned before, or when the electrode is not well placed. Just a few words about focus ultrasound, which is a newer therapy, which involves shooting ultrasound to lesion parts of the brain like the thalamus or the pallidus without opening the skull. The patient is awake during the procedure. We do many of these nowadays. And this is a man with writer's cramp before and 1 month after a thalamotomy performed with focus ultrasound. And this is the way he wrote. Dystonic tremor can be treated with drugs, but also with surgery. This is a meta-analysis of reported cases that we put together, and you can tell that there are a few cases here and there. And based on that, we came up with this flowchart on how to treat dystonic tremor. If the dystonic tremor involves the arms of the head or vocal cord, you start with anticholinergics, plus minus tetrabenazine or clonazepam. Remember the ABCD approach. Some patients might respond to drugs for essential tremor, but if the tremor is isolated to the head, it's usually a no tremor, or the jaw or the vocal cord, botulinum toxin is the first line agent, same as in case of variety tremor. But in case of failure, you add botulinum toxin to drugs. And in case these fail, you might use deep brain stimulation, either treating the thalamus if you want to treat only the tremor, or the pallidus if you want to treat the tremor and the dystonia at the same time. And this is my last slide, just to emphasize that this is a big topic, which I tried to summarize in half an hour. I hope I gave you enough practical tips on how to manage these patients. But this is just to say that not enough is being done, especially in terms of epidemiology of dystonia. Also, the classification needs more work when it comes to dystonia. And lately, not many big papers in the field of dystonia have been published. So research is still there to help us to manage these patients also from a clinical standpoint and in practical terms. With this, I thank you for your invitation, for your attention, and I'll be happy to answer questions in case the Q&A would be allowed. Thank you, and have a great rest of the meeting.